Good day, I am Professor T.H. Bidyani Devi. Today I am going to deal with third and fourth stage of labor, which is also an important aspect and also playing an important role in preventing complication to both the mother and the newborn. Before going in detail about the third stage, uh, we just rewind about the first stage and second stage about the definition of labor. What is labor? So it is labor is a series of movements, series of events which takes place under genital tract in an effort to expel out the product or conceptus out of the womb through the vagina to the outer world. So this is a normal labor, and in the normal labor, we have discussed about the clinical events and the care during the first stage of labor. And continuing with the second stage of labor, we have discussed the principal movement, which is engagement of head, flexion, descent, flexion, internal rotation, crowning, extension, restitution, internal rotation of shoulder, and simultaneously the external rotation of the head, and lastly the bird of the shoulder and trunk by lateral flexion. Like this way the fetus is delivered uh, in this here second stage of labor. It's full dilatation of the expulsion of the fetus. It starts with the full dilatation to the and ends with the expulsion of the fetus. Now, from first stage to the second stage, how we will come to know that first stage is terminated and second stage is begin. So the transition from the first stage of to the second stage of labor is evidenced by some of the features like increasing intensity of the uterine contractions, appearance of wearing down efforts of the mother, and observing a nurse to defecate with descent of the presenting part of the fetus, and a complete dilatation of the cervix. It is evidence as we can see in the vaginal examination. So after the second stage of labor, immediate care of the newborn should be done. We should not go for the third and fourth after just completion of the second stage of labor, as it is evidenced by the expulsion of the fetus. So immediate care of the newborn is important. So once the baby is breathing normally, baby should be dried and wrapped by pre-warm towel to prevent cooling, and handled to the mother to hold and cuddle and enjoy shoulder rooming in. It should be developed. Then if spontaneous respiration is not established soon after the birth, resuscitation should be done immediately, and it should be priority. It should give priority. Then no, it should know the Avgar score of the baby and should be recorded. So like this way uh, we we have dealt with the management of first stage and second stage of labor. Now coming in detail about the first stage of labor. So in third stage of labor, what is third stage of labor? It is defined as a stage which begins after the expulsion of the fetus, and it will end with the expulsion of the placenta and membrane. So main changes occurs in the main thing which happening is mainly focus on the placenta. So it is also known as the placental stage of labor, third stage of labor, or the placental stage of labor. It will take 30 minutes to both the multipara and the primipara mothers. If active management is done, it can be reduced up to 15 minutes. So now, in this management of third stage of labor in detail, here we are going to deal with the delivery of placenta, how it is delivered, what are the mechanisms of delivering. Then after delivering the placenta, we will see the examination of placenta and the perineum, and after the examination we will repair the laceration or the episiotomy which we have given during the process of labor. So in delivery of placenta, we will see that we have two stages. So delivering placenta, for delivering a placenta from the endometrium or the uterine layers, First sign we will see is the separation of placenta from the wall of the uterus and into the lower uterine segment or into the vagina. First separation will be there, then after separation only it will descend down and it will expel from the your genital tract. Second is actual expulsion of the placenta out of the birth canal. So first is expulsion and first is separation of the placenta from the uterus, and the second is actual expulsion of the placenta out of the birth canal. But here we have two mechanisms for separation of the placenta from the uterus. Namely, it is the Matthews-Duncan mechanism. Second is Sulz's mechanism. So what happened in first Matthews-Duncan mechanism? Here we can see in the image also that placenta can be separated. Placenta is round, hard, round disc-like structure in anatomy. If we see, so the whole placenta is attached to the uterine layers. So while during separation of the placenta from the uterus, separation can be of two methods. That is, marginally it can be separated, or the central portion of the placenta can be separated first. So in first method of Matthews-Duncan mechanism, the leading edge, the margin portion, the edge can be separated and it maybe comes out first. So the leading edge of the placenta separates first and the placenta is delivered with its row surface exposed. Here in the image also you can see that the leading edge is coming down and the portion of the placenta is above, and the leading edge will lead to descent, and the other parts will follow. Then in Ansel's mechanism, if the placenta is inserted at the fundus and central area separates first, here the it is its placenta is like an umbrella. If the separation is at the central part, so it will we can imagine like an inverted umbrella. So the placenta inverts and then draws the membrane after it and covering the row surfaces. So in first mechanism, the row surfaces is exposed, but in the Sulz's mechanism of placental separation, the row surfaces is inverted and it cannot be seen. And this image also we can see. The first image is about regarding the Matthews-Duncan mechanism, and second is for regarding Sulz's mechanism. In both the condition, bleeding will be there as there is placenta is separating, so automatically bleeding will be there. But here in the condition of bleeding, Duncan mechanism bleeding will be little more than the in the beginning will be little more than the Sulz's mechanism, as in Sulz's mechanism there the separation of the placenta is central, it is eccentric, but in Duncan mechanism it is eccentric, so it is marginal, so bleeding may be seen early. So here you can see in the image Duncan mechanism, the edge is coming first and the remaining portion is following, but in Sulz's mechanism it is forming an inverted umbrella. The central separation is holding the blood. Bleeding will see, we can see the bleeding will be occurred, but initially blood will not come more as in the Matthews-Duncan mechanism. So now it is regarding the methods of placental separation, but how we can understand that placenta is separating. So next we will see the signs of placenta separation, how we will come to know that there is placenta separation is initiated. So we have signs of placental separation. The placenta should be within 5 minutes after the delivery of the infant, after the delivery of the new fetus. So it should be started. So first thing is the uterus becomes globular and hard So when we assess, when we palpate the abdominal part, so uterus, we will feel by our non-dominant hand that uterus becomes globular and it becomes hard. So this is the first sign or earliest sign to that we can observe. Then second thing is sudden gush of blood. We can see suddenly blood will come out after the fetus is expelled. Then the third one is the uterus rises in the abdomen because the placenta, having separated, passes down into the lower segment of the vagina, where this bulk will pushes the uterus upward. Then if it is separated and your placenta comes down, uterus go back, and it is this bulk pushing the uterus upward, so automatically there will be, you can see the length of the cord is increase in the sense that around average length of the placenta cord is 50, it will not increase up to 60. It means what, how much cord length of the cord we can see from outside, it will be increased like around 20 centimeter. If we are seeing the length of the cord, it will be increased as placenta is coming down. So there will be, you can see the lengthening of the cord. Now the active management of third stage of labor. So in definition, we have discussed that uh, it is it a time taken during third stage can be reduced if we follow the active management of third stage of labor. So it will help prevent the postpartum hemorrhage, which is an important factor as a causes of maternal death. It will active management of third stage of labor will include the use of oxytocin, control cord traction, and uterine massage. So here, use of oxytocin is an important part. Until unless oxytocin is administered, control contraction cannot be done. So use of oxytocin should be done with after assessing how much international IU can be given, and after creating the contraction. So next is control cord traction and try massage. In control cord traction, here you can see in the image also that we, by the non-dominant hand, we should uh, massage or palpate the uterus, and we should only do this if she has had ergometrin or oxytocin already administered. Oxytocin can be given or the ergometrin can also be administered. Ergometrin or the methargin 0.2 mg can be administered IM. If the mother is having a cardiac condition, so we should avoid ergometrin or methargin. We should go for oxytocin, as the ergometrin or methargin directly acts on the myometrium of the uterus, and it is causing burden or workload on the cardiac, on the heart of the mother. So in the image also we can see that you can see that we should pull the cord which is wrapped in the clamp. We should pull it gently. It should not be hurry, and by non-dominant hand, as soon as the uterus feels hard, it should lift it towards her umbilicus. And this is the way in the beginning, and after that our non-dominant hand should massage on the abdomen, and our dominant hand should first pull downward and little backward, and then more on the anterior portions, or it can be released easily and in a soft manner. So once the sign of placental separation has occurred, that we have discussed, the four signs of placental separations occur, the obstetrician or the acoucher should assist delivery of the placenta. It should be by control cord traction, as it is described by Band's Andrews method. And if the patient is awake, mother should be asked to bear down while gentle traction is met on the umbilical cord. So if usually the mother awakes, if but if in some condition, if the mother sleeps or closes her eyes, so she should ask to bear down while gentle traction is met on the umbilical cord. So like this way, it can control cord traction can be done. So in short, we can summarize in the image. So with the dominant hand, we should pull gently, while simultaneously by non-dominant hand, we should lift it towards the umbilicus of the mother. And in the second, we should pull gently downwards and backward. Simultaneously, by the non-dominant hand, we should pull it backward. And in the third image, uh, we should pull the cord by slowly rotating and little downward and backward and more anteriorly later on. And this time our non-dominant hand should push not to the umbilicus of the mother to the downward condition. So in this condition, how much what we should do, components of active management of stage of labor, it is according to the FIGO ICM, associated by the many studies and criteria we should use to measure the compliances. So first we will see the use of uterotonics. Here, regarding the use of uterotonics, preferably oxytocin we will use with the ergometrin and the misoprostol or other prostaglandins as second line drugs. The prostaglandin will help in the ripening of the cervix. And so next is doses of uterotonics which we are using. If we are using oxytocin, we can use 10 international unit, and if we are using ergometrin or like example methargine, we can use 0.2 mg/m, and if you're using misoprostol, that should be 600 microgram. And stages of labor immediately after the fetal delivery, when we should do this remedial measures. So the timing is the immediately after the delivery of the fetus, we should select this is the ideal time. Then timing of uterotonics, when should we give, when should we administer uterotonics. It should be within 1 minute of fetal delivery, after within 1 minute of fetal expulsion. It should be done immediately within 1 minute. So mode of administration should be according to the electronics. We are using oxytocin and the ergometrin. If we are preferring, then it should be given IM injection or IV injection, or it may be IV drops or IV push after the induction or augmentation of labor. Induction is just initiating the labor, or augmentation means it is accelerating the progress of labor. And if we are using misoprostol tablet, so we can administer by using the oral route. So here is the mode of administration: oxytocin or ergometrin is IM, IV or IV drip, IV both it can be two, and misoprostol is we should use oral route. So next is control cord traction. Here, gentle application of the traction to the cord should be done with manual support to the uterus should be done. So manual support to the uterus, in the sense, in the image we have seen that by non-dominant hand we are massaging, we are assisting the separation of the placenta, release of placenta through the abdomen. So this is the gentle application of traction with the manual support of the uterus. Manual support in the sense by our hand, which should support the uterus. Then frontal massage immediately after placental delivery. This component as also it is same uh, as it is in the control cord traction. Then uterine palpation every 15 minutes or 2 hours after placental delivery. For practical purposes, this is observed that it provide palpated uterus for at least twice during the first 30 minutes of uh, postpartum. Next is examination of the placenta. So here examination of placenta and the membranes. First is The placenta and the membranes and umbilical cord should be examined well for completeness and for any anomalies which we can see during the examination. So, at the same time, the perineal region, vulval outlet, vaginal canal, and the cervix should be carefully examined, and for the lacerations also, which it can be occur if we are not giving episiotomy in time. So, if the perineum has been torn or an episiotomy met, or a tear or incision should be repaired immediately. So if we are going uh, in detail about this placenta examination and perineal placenta and the perineum examination. So here we can see what is placental examination. We should placental examination is and a thorough inspection and the examination of the placenta and the membranes or the perineum soon after the expulsion of the fetus for its completeness or any to detect any anomalies or to see any to see the normalcy condition of the placenta and the membranes. So we know that placenta anatomy of the placenta, how much it weighs, how what are the surfaces and the lobes which are present on the uh, maternal surface of the placenta, the length of the size, the cord insertion, and the petal surface condition, the layers, the blood vessels, how the pattern it is radiated, whether it is the placenta is abnormal or normal, like buttermilk placenta, suction choriata, the size, small size, large size, cord length, everything we have to examine here. So why we are examine the placenta and the perineum? The purpose is to ensure that we should ensure that the entire placenta and the membranes have been expelled and no part has been retained. If it is retained, then it can cause infection or sub-involution of the uterus. After delivery, involution of the uterus is much more important, but if some part has been retained inside uterus, then sub-involution may arise. It can again cause sepsis afterwards. Another purpose of placental examination is to make sure that placenta is of normal size, safe, its consistency, and weight of the placenta. Uh, and to not only this, it is just to detect the abnormalities. This examination is not only to make sure that the placenta is of normal size, safe, and consistency in the weight, but also to detect the abnormalities such as infections, calcification, or additional lobes, which we can see in the maternal surface of the placenta. Regarding infection or calcification, we can see a little grayish color deposition on the fetal maternal surface of the placenta. And is there any additional lobes or is there any missing lobes? Uh, if regard around 17 to 22 lobes, we can see 17 to 20 lobes. Here if we found 18 lobes, we should assess it appropriately with accuracy. It may be 19 lobes, one lobe is missed inside, is retained inside, and we are finding only 17 lobes. So if some portion of the lobes is retained inside, by seeing the surface we can see clearly that there is something, it is separated. uh, Next, it is to purpose is to ascertain the length of the cord and the number of the blood vessels and the site of the insertion of the cord. We are examining the placenta. Length of the cord, we can see the average length of the cord is 50 centimeter. Number of blood vessels, it is two. There should be three, two veins and one artery, and the site of insertion of the cord, whether it is marginal or eccentric. Then to check the weight of the placenta and measure the length of the cord. So there are many reasons for expulsion for the purpose of there are many reasons for examining the placenta. uh, So, while doing examination of placenta, we should not do with our naked hands. We should wear gloves to protect ourselves from contamination. And we should use using glove hands. We will hold the placenta by the cord, allowing the membranes to hang on, twisting the cord twice around the fingers while will provide a firm grip to the placenta and will identify the hole through which the baby was delivered and insert the hand through the hole and spread out the fingers to view the membranes and the blood vessel. We will remove the hand from inside. Like this way we should assess the membranes and any layer of the placenta on a flat surface with the fetal surface up. Then identify the site of the cord insertion, that is automatically on the fetal side. The radiating vessels you can see here. Then we will see the two membranes, examine the two membranes, that is the amnion or and the chorion, for completeness and the presence of abnormal vessels indicating the succenturate lobe. This which is a part of which is one of the abnormal placenta. So amnion is normally shiny and the chorion is shaggy, little bit shaggy, and the amnion can be peeled from the chorion up to the umbilical cord. Here in the umbilical cord it cannot be peeled off. So other portions of the placenta, this amnion can be peeled off. The outer layer is chorion. And after this, I will invert the placenta, expose the maternal surface, and remove any clots present. Then we will examine the maternal surface by spreading it in the palms of our hands, and placing the cotyledons in close approximation so that we can observe it with more accuracy. Like we can see some broken fragments, it should be replaced before accurate assessment is made. Then we should see for a presence of abnormalities like infarction, calcification for accentuated lobes. Then we will inspect the cut end of the umbilical cord for the presence of three umbilical vessels. Two arteries and one vein should be normally seen. Absence of an artery may be associated with renal abnormalities. So there should be two arteries and one vein. And we should measure the length of the umbilical cord by holding it and extend it against the graduated surfaces side of the weighing scale. It should be measured. The average length of the cord is 50 centimeter. Placenta should be weighed by placing it on the weighing scale, which is for the weighing of the placenta specifically. Normally the placenta weighs about 1/6 of the fetus of the newborn weight. Like if it is 3 kg, then the average weight of the placenta will be 500 gram. Then it should replace the placenta in the vein for the proper disposal of BMW by medical waste management as it has been described. Then we will clean the area used for the examination of the placenta and membranes, then weighing the scale and the ball and everything, the equipments we used. Then we will remove the gloves and we will wash our hands with the proper steps. Then we will record in the patient chart the findings of the placental examination and the weight and the placenta length of the cord and any special observation which we have observed, we have found during examination. It will communicate between the staff members or between the caretakers or healthcare team. So see, this is how placenta examination can be done, and the vulva examination can also be done. After this, here comes the time for repairing. So if the parent has been torn or an episiotomy given or tear or incision is made, it should be repaired immediately after complete assessment and the cleaning, which we have done in the placental examination and membranes. Here, in repair of episiotomy or the tear or the laceration, suturing should be done as soon as possible after delivery to avoid bleeding and infection. Then we will start just above the apex while exposing. Why, if it is the perineal area is exposed, we can see the apex portion. It should start suturing should be started just start just above the apex, and we will use three layer techniques. The first is vaginal mucosa, perineal muscle, and the perineal skin. So here are the three layers we should do suturing. Then synthetic absorbable suturing material should be used. It is actually rapidly absorbable polyglactin 9 to 10, and Vicryl, it is Vicryl rapid. It begins to fall off 7 to 10 days post operatively. So we should select the suturing material appropriately. Then this is actually reducing the postpartum perineal we will reduce the postpartum perineal pain and the dyspareunia. 4 days for this layer, use loose continuous non-locking suturing. This will help in reducing pain and dyspareunia. So this is how we can reduce the pain and dyspareunia by using loose, continuous, and non-locking suturing. Next, we will see the how we will do suturing and what are the measures or criteria with which we will follow. First is we should identify the apex. Uh, if the perineal area is exposed, we can find a perineal. I don't know. We can find apex. We can see that. Then we should start suturing 10 centimeter just above the apex. Then continuous suturing should be done. Then ends at the level of vaginal opening. So here in the first image, the type of suturing we are doing is continuous suturing. Continuous suturing in the sense there will be no making of no knots in between the suturing. It should be done in the vaginal mucosa. And in the second image you can see the progress in the suturing condition. It is muscle layer. Here we can use the interrupted suturing. And in the third image you can see the suturing of the skin. The portion which we have sutured previously can be seen inside the skin. So here we can use interrupted suturing or subcuticular. In the rutted suturing, we are more using here like mattress suturing. It is more appropriate for suturing in the skin. Next, after suturing, completion of suturing, we should make the unit neat and tidy. The mother should make comfortable and everything. It should be wind up, and we should give the baby feed a newborn to the mother so that roaming in can be developed. And as soon as possible we will try to initiate the breastfeeding. Now coming to the management of fourth stage of labor. So here we know that it is mainly it is here there is no such even soft labor as it is fetus is expelled and the placenta membranes are expelled out, everything is completed. Here fourth stage is important because labor is such a critical condition. Being saying normal labor, it is itself is an abnormal condition. It is very the labor word itself, it's a very critical and life-threatening condition. So after third stage, management of fourth stage is very important. It's pivotal stage. Here many ups and down, many fluctuations can occur in both the mother and the baby. So this time we have to observe both the mother and the fetus and check everything. We should monitor all the vitals, all the fluctuations to come to normal. First is in observation, the 2 hours after delivery, which is a critical phase for both the mother and the fetus. This is regarding the first stage of labor. So in the observation, postpartum hemorrhage can occur due to relaxation of the uterus. So in observation in delivery suit, bleeding we should assess regarding the bleeding patterns and the nature, how much ml bleeding is occurring, and how much spared it is changing, any signs of infection it can be seen or not, then blood pressure, pulse, temperature, everything it should come to normal. During labor, if the pulse is raised, it's normal because labor is an exhaustive procedure, and if the temperature is raised, it can also be considered as normal because of breakdown of protein or exhaustion. But after the delivery, the puerperium chart should come to normal. So we should assess for these fluctuations in the vital signs. Next, so after monitoring, we will check before discharging the patient from the delivery. First, in the uterus, we will frequently to make sure it is firm and not relaxing. The relaxing uterus can cause the postpartum hemorrhage. So postpartum hemorrhage can occur due to the relaxation of the uterus. So we will make sure that it is not relaxed, it is firm. So remove any presence of intrauterine blood clots. Clots interfere with the retraction and normal hemostatic mechanism of the uterus. Retraction in the sense, this is also a part of the physiology of the labor. It is the permanent shortening of the uterine muscles, which is an important aspect during the puerperium period. And in introitus, to see that there is no use, there is no tear. Then in bladder, bladder should be kept empty. Full bladder can also interfere with the uterine retraction, which is a permanent shortening of the uterine muscles. Then for baby, breathing condition, breathing pattern should be assessed. Breathing should be proper, it should be well, and that of the color, tone, everything should be checked. It should be normal. We can see, we can compare with the Apgar score. With the Apgar score, we can assess the baby's condition. So this is regarding the fourth stage of labor. With this, whatever the necessary investigation it should be done, it checked out can be checked out, and the further um, discharge education should be given to both the mother and the attender, which are along with the mother or the family members, so that they can take care of both the mother and the fetus at home. So with this discharge advice, we will with the follow-up advice we will discharge the mother and the fetus. So this is regarding the third and fourth stage of labor. Thank you.